We are thrilled to announce that today we have the honor of having Peter Sullivan here with us. Peter is a specialist in musculoskeletal physiotherapist, a distinguished professor at Curtin University, a researcher, and one of the developers of the cognitive functional therapy approach. Peter, thank you for being here with us. Thank you.
That's a pleasure.
And welcome to Physionauty Podcast.
Welcome to Physionauty Podcast, of course. In this podcast, Peter, we talk about pain management and psychologically informed physical therapists. So our audience is used to hear about these topics. So we have read a lot of your articles and attended some workshops, and we try to use cognitive functional therapy in our clinic. So based on this information, we wanted to dive deep into the topic of cognitive functional therapy, if for you it's okay. And we would like to start with a question. We were asking ourselves if you think that this approach, if there are patients for whom this approach fits better, or others for whom this approach is ineffective.
Yeah, so there's probably a lot of answers to that question, and we're trying really hard to find that answer out in our research as well as what we see in the clinic. CFT is like a model of care, basically. The model of care is about helping people make sense of their pain. It's person-centered. It drives them towards their goals. It builds confidence back in their body, and it helps them to address a healthy lifestyle. So it takes two people to tango, right? Mm-hmm. So if the person doesn't want to play tango, you can't dance with them. So if you have someone who comes to you who says, I've got no interest in taking any ownership. I just want you to do something to me. I don't want to take ownership of this problem or work towards taking control over this problem. Then it's very hard to use an approach like CFT because it demands a partnership. And that's what the dance is. You can't make someone dance, but you as a clinician can learn to dance their dance, right? But they've got to want to dance. So if you got someone who doesn't want to dance, then this approach won't work. And so that's a conversation, I think, around pain in our society, because we have really strong views in society that if you have pain, there's something broken, it needs to be fixed. And so it makes sense that people go for a scan. It makes sense they go and see someone, that they get surgery, or they try and get a prosthesis or a fusion or whatever. But we need a conversation with society to say, actually, chronic pain is like any other chronic health condition that needs a fundamental shift in understanding and a partnership where actually we empower the patient to learn the skills to effectively self-manage their condition. So that's a conversation that's needed. Now, not everyone wants to play that. Mm-hmm. But, like I've literally just come from the clinic today, and, I saw two people with just such sad stories of the devastation of what the current healthcare system does to people. Multiple surgeries, multiple injections, pile of drugs that don't work, that has left the person completely disabled, not able to work, socially isolated, depressed, anxious, stressed. That's what we're doing in our healthcare system. We need a different conversation around that. Now, this person amazingly still had an element of hope. Mm-hmm. But when I asked them, what's your biggest barrier to getting your life back? They said fear. Fear. I'm frightened. I'm terrified of the pain. I'm terrified of the consequences of the pain. I'm terrified that if I have pain, I can't go to the shop. I can't care for myself. So we have created fear in our society with the way we understand pain, the way we treat pain, the way we give false solutions for pain in our health system. We've created a monster. But because of that, we have a society that has a fundamental belief that you need to be fixed and that someone needs to fix you to do it. And that's the tricky bit with an approach like CFT, which fundamentally is an empowerment model of building confidence and tools back in the person to take ownership. Not everyone sees that as even an option. Not everyone knows that it's possible. Not everyone wants to walk that journey. So it's a really long answer to your question because it's tough.
Yes, it
The
is.
other person I sorted out, I'll give you another example. The other person sorted out, again, like majorly disabled, had so much treatment. And at the end of the session, she's going, do you think I need a rub? I'm like, I can give you a rub. No worries, I can do it for you. But how long has a rub lasted in the past? She goes, you know what? When I've had a massage on my back, I've gone to the car after the treatment, I'm back to where I was. So why would I give that to you, given that's your experience? I'm treating your symptoms, not the cause. And as a health professional, I hate doing that.
Mm-hmm.
So they are the conversations that I have every day with the people I work with. And they're difficult conversations, right? Because as manual therapists, we know we can give pain relief, but we know we're treating symptoms. We're not addressing causes. And we can do both. That's okay. But we get stuck in the other, I think. Our whole system's stuck in it. It's why we've got such a burden of disability in our world.
Yes. Peter, I am amazed by your answer because I asked a question in which there were only two parts, the therapist and the patient, but it's incredible. The answer you gave highlights that there is needed a shift in society, because without a shift, a change in society, there's no possibility.
It doesn't make sense.
Yeah, of course.
Yeah, and that's why that's why it's such a wicked problem, because it's so multifactorial. It's a problem with health systems. It's a problem with health practitioners. It's a problem with our identity. It's a problem with our egos.
Yeah, it is.
Our egos are saying, "Oh, I can fix you." It's not about our ego. It's about empowering the person.
Yes.
And we got a problem in our society where we think these things are simple and they're not simple.
Okay, so if I can say one thing. So if I got it right, we are in a system which really treat the chronic pain like acute pain, and so it creates a lot of.
But even acute pain's treated badly.
Okay.
Because if you think about it, most acute pain is acute exacerbation of a chronic problem anyway.
Yeah, relapses.
You can have acute pain. Look, if you think of how we treat acute pain, we treat everything like it's damage. You can get an acute headache. That's not because you banged your head. Yeah. You can get acute back pain because you're distressed and there's shit going on in your life. Or you can have an acute pain where you fall off your bike and break your back. There are different kinds of acute pain. Mm-hmm. But we think everything is about damage. And there's so much more to pain than damage.
And even if there is some damage, I think
we overprotect it.
Yeah, or overtreat it.
Massively overprotect it. Yeah, we overtreat it, we overprotect it. We tell people crazy things about their pain. It devastates people. And of course, where there is identifiable tissue damage, you do need tissue healing. Of course you do. But tissue healing is not a mobility, because we know that tissue doesn't heal if you completely immobilize it anyway.
Yeah. We have to change something even when there is some tissue damage, because we overtreat, overprotect, and
massively.
Sometimes is another part of a iatrogenic part of disability and suffering around us, I think.
Massively. Sometimes I think we'd be better off with no health system for pain than a health system.
Yeah, like the Aborigine.
I would say 99% of my work is dealing with iatrogenic disability and distress.
99?
Yeah, 99 is a lot.
I do agree.
Yeah. Sorry?
Yeah.
Yeah. Like it's so depressing. It's actually depressing because I hear these stories of unnecessary suffering, of unnecessary distress, of unnecessary pain and disability. It's so unnecessary, and people are completely surprised that actually there's a possibility for something better because they've been sold this lie by healthcare.
But Peter, if I can ask, you already mentioned something, but what do you think that are the causes of these problems? So why healthcare practitioners believe everyone is damaged? Is that because of money? Is it that because of insurance or ego?
No, I think these are deep social beliefs around pain.
Okay.
I think we deeply, where do we learn pain? We learn it from our family, from our peers, from our society, from trainers, from nurses, from doctors, from, our parents. That's where we learn pain. We learn it at a very young age. How you respond to an injection teaches us about pain. How your parents respond to you when you fall over and you cut your leg is about pain. That's how we learn pain. And we know this from our research that if you ask young people about back pain, they think it's bad. They think it's going to get worse. They think you need to rest it. You need to protect it. And if you have those beliefs and you have pain, you're more disabled. You're more likely to not engage in physical activity. You're more likely to take drugs. You're more likely to seek treatment. And you're more likely to then take time off school. And then you're more likely when you're an adult to take time off work. Like this thought virus begins really early in life, and it's everywhere. It's everywhere. How we teach people about the body, the risk in the body, how we educate them about pain happens really early.
And Peter, can you think we can say that part of our job is to bring these people back to natural, normal relationship with pain and their disease, like in some way erasing all the overstructure thoughts the society bring them, like helping them to work with their pain like an aborigine.
Yeah, it's hard. It's really hard. But, I think we're lucky around pain in that so many of the behaviors because pain's really aversive, right? Like, I get pain in my body pretty much every day of my life. But it's a reminder for me. Have I had enough sleep? Have I been for some exercise? Have I been working too hard? Have I done too many podcasts this week? Like it's my point of reflection, right? Yeah. But that's a conversation we need to be, and I think we've got to get away from this idea that we should be pain-free. That's not normal. Like there's so much more to pain than a pain score. Like you guys go to the gym, right? I presume you guys exercise. Like how much pain do you feel? It's good pain. Like you get an 8 out of 10 mountain biking. Yay. Like that's not bad pain. So in pain score, pain is so much about meaning. I mean, people pay for pain. People pay to go to someone who causes them pain because it gives them pleasure. That could be 9 out of 10 or 10 out of 10. Like pain is about meaning. And when the meaning of pain means it's a threat, it might threaten something that's really important for you. It's got a different meaning. And that's where you start seeing those beliefs around pain and those emotional responses around pain and the behaviors around pain start getting all looped up. And the beauty that I think in our job is that we can use behavioral experiments to demonstrate to people that actually not protecting the body hurts less.
Better.
Yeah. So that's such a cool thing because then it's not about us telling them, it's about their experience shifting their own way of thinking. And that's why less of the talking and more of the doing is the key, that actually let their experience teach them rather than me telling them.
Yeah. Let me ask you something about this. When did you learn this importance of the behavioral experiments compared to the education? When you learned that you had to talk less?
You know what? I made a decision. It's a good question. And it's probably a hard answer for me. It's probably hard for me. I've always loved listening to people's stories, always. And in my early career, I worked in clinical practices where I was seeing people on 20-minute appointments, and I hated it. I never had time to hear the story of people. So this is making me feel old, but in the mid 90s, I changed how I worked. I thought I'm never going to work this way again. So I ended up spending I'm putting an hour appointment for my initial assessment and then half an hour for my follow-ups. That was the best thing I ever did in my career. That was probably the most important thing I did in my career, apart from, having wonderful mentors. But it gave me time. It gave me time to think. It gave me time to listen. It gave me time to play. It gave me time to experiment. It gave me time to be brave and courageous to do something different, because I was seeing people who I knew I couldn't help with my manual therapy techniques. So that was probably the beginning of a shift, I think. But, and I've learned so much from people I've not been able to help. People who I've made worse, who've come back to me and I've gone, whoa, you trusted me enough to come back and tell me that actually what I've done for you is really not helped at all or made you worse. So they've been really important teachers for me. And I think if we come to a clinical, probably the other biggest thing I reckon is shifting the lens around to go, it's not my agenda as a clinician, it's about the patient's agenda. How can I honor this person's agenda in the way they in their needs and their concerns? How can it not be less? Can it be less about me? And I think that was hard for me as a manual therapist, because it was about, I've got great hands. Like I can crack bones and I can give people a rub and I can make them feel better. And I can still use those tools right now. Like today, I was in the clinical day, and I still use hands-on approaches, because touch is such a potent and powerful therapeutic tool. But the whole meaning around touch has changed for me. I use it as an opportunity to build confidence, of reinforcing how wonderful movement and activity that's non-protective is. So, it's multi-layered is the answer to your question. But fundamentally, I knew in my career I had to do something different or I was going to drop out. And I've nearly left my profession twice.
Oh, wow.
So when I first graduated, I nearly left because I thought, this is crazy. I was just like, there's no evidence for this job, so I'm going to do something different. And then I nearly left again after I graduated I worked for 3 years, and I'm like, oh, I can't do this anymore. I'm treating symptoms, and I'm not treating. I don't know what I'm treating. I'm treating literally. I could be treating cancer. I don't know what I'm treating. I was just treating symptoms, and I hated that. That really deeply unsettled me.
Just trying to reduce PRS scores,
Peter,
it was horrible.
Yeah, thanks for sharing, because I think that the problem of burnout is super common in our...
Because
field.
we're taking it. We wear it. I used to go home feeling so stressed, thinking, oh my God, I need to learn a different technique. Like, maybe my technique wasn't right. Maybe I was getting the wrong level or the wrong direction or the wrong grade, or it's like, it was such a horrible place to be, because it was on me that I couldn't help this person.
Yeah.
Where when you're walking in partnership with someone, it's about shared journey. So much better. So how can I support you to meet your goals? What a cool process. So it takes so much pressure off you as a clinician.
Yeah, that's true.
It's so much more.
I've never thought this way, but that's super interesting, because I had this feeling that I was doing things I wasn't understanding what I was doing, and then still believing I was the problem. I was not good enough. But then if you focus more on the other person, on the other human, that shifts the whole picture. That's a super Beautiful.
And just that question to say, hey, how can I support your journey? Like, tell me about your goals. Like this lady I saw today who she wrote on her form, my goal is pain relief. At the end of the session, she goes, my goal is to do A, B, C, D, E, F, and G. And I'm like, that's not what you wrote in your form. She goes, I couldn't see it. But now that made me think about it, I want to do this. I want to travel. I want to go to the beach. I want to, I want to, all of these things I want to do. She couldn't see it because pain and anxiety and fear were just like a barrier. They're like someone who's, frosted your window and you can't see what's beyond it. And I think what we do in a, patient-centered care is about together clearing the window screen. It's like, ooh, that's cool.
Super interesting. Yeah, so you're saying that patients almost forget that they can get back to those activities that they really love.
They lose hope.
Lose hope, and then from the system and on whatever.
And they accept that their lives are miserable.
Yeah, and they just focus on lowering the pain, and that's it.
Yeah, just so horrible.
Yeah, and also you said that in your first consultation, in a way you could help this person see that they have hope and that they could get back to those activities, that we have options to do that.
Yeah, you bet.
A lot of physios struggle to do this shift that you just mentioned.
Yeah, it's hard. Look, it's so hard. Like we had this meeting with the physios who were in the Restore trial. And one of the things they said was really, really helpful in their training was we told them they couldn't use any manual therapy with their patients. And they're like, what do you mean? The patient's going to get angry. They're going to be pissed off with us. They're going to be going, what do you mean you can't do manual therapy? And then they realized that actually the goal of the patient wasn't manual therapy. The goal of the patient was to get their life back. And all of a sudden it was like their anxiety. It was about their identity. It wasn't about the patient's goals at all.
Yeah.
Now, that's not to say you can't use manual therapy as a tool, but you don't need it. It's not necessary.
And why in the Restore trial did you decide to restrict the use of manual therapy?
Well, because we wanted to build the self-efficacy of the clinicians to realizing that the tools in their toolbox were so much better. These other tools were so much better that actually, if I can give you pain relief or I can teach you how to give yourself pain relief, which is better? It's a discussion I had with this lady today. I said, how much cooler would it be if I give you strategies to reduce your pain and get your life back that you can use every day of the week? Because you don't want to see me every day of the week. How much better would that be? That you empower someone else to go, hey, I've got control of this thing. I can self-manage my pain. I can get back to the things I love. Manual therapy never did that.
Yeah. Amazing. So almost like unchanging the taking off change from physios that they need to do sometimes manual therapy, because as you say, symptom modification can be a great tool if you use it wisely. Yeah. But it can also be...
But it can be an awful trap because the person goes, hey, I'm now dependent on you to do that thing.
Exactly.
And then we're trapped. And I've trapped myself 100%. Got myself into a trap where people keep coming back and go, oh, I need you to do that thing again. I'm like, this is... How long does it last for? A couple of days? I'm like, come on. That is not cool.
Not
now,
enough.
if you want to pay for it, that's fine. But if you want a long-term solution, let's talk about it. I mean, it's, I wouldn't deny people that, but, if someone's fully functioning and they've got aches and pains, that's fine, no worries. But if they're seriously disabled and distressed, that is not okay. That's where I draw the line.
Yeah, I do agree.
Okay. Peter, what are the skills that a therapist needs to work with this approach? What do you think? Courage. Oh, wow.
Courage. Yeah, I think, it's hard. Like if we ask the...
Unexpected answer, but wow.
Unexpected. I've got lots of unexpected answers. I think we have to be courageous with pain, right? We have to, I think fundamentally, we have to have a positive mindset around pain. Like I look at people who walk into my room, like this guy today comes in with a brace, a walking stick, you know, seriously disabled, spends most of his day lying in bed. I believe he can change. I bet you most people wouldn't. I believe he can change. Like change is fundamentally possible. That's something we need to believe. And that's one of the things that we saw in the Restore trial. It's why we work with patients in the Restore trial with the training. It's like we brought in people who are really disabled and distressed, and they're like, oh my God, I don't think I could help this person. And they saw change happen and they're like, wow. Actually, if you see it, it starts building your self-efficacy as a clinician to go, actually, it's possible. So what is that? That's a mindset in ourself. And, if you think of CFT, which is a mindset change, it's a behavior change, and it's embracing the behavior. That's what we go through as clinicians around what's your beliefs around pain? What are your behaviors around pain? How do you help people in that journey? What are your clinical behaviors? How do you communicate with somebody? Do you shut them down when they start becoming distressed and they cry in your consultation? Do you hide those conversations where they're talking about the distress in their life? Because that's what a lot of clinicians do, because we're not comfortable with it. We want to deal with the structure. We don't want to deal with the fact this person's socially isolated, they were abused as a child, that they're got major anxiety and comorbid depression, and they have no way of getting out of that. We don't want to deal with that because we're not skilled. So, that's the journey. We wrote with my colleagues the paper around what are the competencies that you need as a pain clinician. They're communication skills. They're fundamentally a different understanding of pain. They're about working as a coach to empower people. They're about goal setting, about validation, about shared decision making, about empowerment, about using behavioral experiments, about lifestyle coaching, about motivational techniques. That's why our job's so cool, because it's not just one thing. It's a big toolbox, and we use different tools for different people. But if you have a small toolbox, you use the same hammer every time for the same patient, it doesn't work.
Well, so what I'm thinking is that we as practitioners are scared now when we want to embrace.
Massively.
And when you did, I think that what you did is giving them tools and techniques and training, and then with their experience, the confidence build up. I bet that they weren't confident during the training, I guess, right?
And they said, we know what you're doing. You're doing to us what you do with the patients. That's what the physios told us. You're CFTing us.
You're shifting.
We're testing our beliefs and our behaviors, and we're getting us to reflect on them and change them in our own clinical journey. And of course, that not every clinician wants that, because it can be threatening. It can be about your own comfort with your own emotion. If you're not comfortable with your own emotion, you won't be comfortable with someone else's emotion. So that's a whole shift around us as a healthcare practitioner, to be comfortable with a person's distress, to be comfortable with their fears, to be comfortable. But also we need to be skilled to make sure we're not reassuring them and they've got pathology as well. So we need to be able to triage them. But, we're dealing with a very small group where there is specific pathology.
That's a hard work for the therapist himself, because they have to be the person that makes the job. I think that's the difficult part. And then I think that...
But how cool is that?
It's super cool.
Boring is life? How boring is life if we don't grow?
Yeah, we agree, I think. Yeah. And then I think that one problem that I hear when I talk to physiotherapists here in Italy, the problem is that we go to workshops, we come in contact with those ideas and those concepts, and then we go out, and then we go in workplaces, and the situation is super bad, and everyone gets super frustrated. We need to build a community, I think, because otherwise it's very hard.
Yeah. That is 100% supported in our research as well. Like if you're alone in a community, it's super hard. If you're a lone voice, it's a bit like climate change. If you're hanging out with a whole lot of climate deniers, it's very, very discouraging, right? Everyone's going, oh, that's bullshit. You know, burn those fossil fuels. You know, who cares? Like, you don't want to be advocating for a healthy planet when the rest of the people are burning it.
Yes, yeah, that's true.
So building community, I think, is probably one of the most important things that we see as a team, to go, you know, we're dealing with, you know, pain is tough. Like it's, you know, if you're dealing with people disabled by pain, it's tough. It's a tough job. It's very demanding. It can be lonely. And so having a team around a community who you can share that with and support is so important.
What do you think is for you? What do you think it's the hardest part of for us as clinicians for working with pain, or in this context with chronic pain?
Put our egos away.
Okay.
I honestly, it's probably the thing I've learned, and I still trip myself up by putting my ego in front instead of putting it behind. It's just human, I think. But probably the more experienced that I am, you know, the more I reflect how important that is like, you know, we come to we have a role, and I probably, because, you know, I have a title as well. Like I have a title, like, you know, I had this young woman today, she's 18. When she was 14, she hurt her back, and she saw a surgeon who said, look, you know, you got to stop all the things you'd love. She was doing dance and gymnastics stuff. You got to stop it all. And you could end up being paralyzed and have surgery. That terrified her. For the next 4 years, or no, probably 5 years, she stopped her life, right? Like completely stopped. And like I reviewed her. She was frightened and distressed, and like, you know, that was not about me. It's like, what do you want back? How can I support you? What do you need? And like, in her head, her back was damaged. You know, she was terrified to move. She had so much sadness and distress because she'd lost the things in her life that she valued. And to me, it was like, what can I do to support you to get back to the things you love? Now, she said to me today, she goes, you know, this is so different. I've had so much physio before, and it's always stuff. I have to keep coming back week after week after week. I've seen you 3 times, and I now have no pain, and I'm going to the gym, and I'm getting strong, and I'm getting confidence. Why is it so different to what I've had before? Like, you've not done stuff to me. You've just coached me. She goes, that's what I want. I've been asking for this for 5 years. Why is it? Now, I could have done stuff to her, you know, made it about me. Once upon a time, that's what I would have done, because I wouldn't have known how to do anything different. But that gives me so much joy as a clinician. It's such a wonderful, joyful thing to be able to build someone's hope back. She's going, you know what? I don't think I'm ever going to need that surgery. I never told her that. She found it for herself. It's through her experience she got to that point. So that's less about me. That's probably the hardest bit, I think. And, you know, being adaptable, being playful, taking risks. We have to take risks.
Yeah.
What if person goes, oh, you know, if I don't do this, I think my back's going to break. It's like, yeah, let's give it a go. but you know, I'm lucky in the sense that I'm fundamentally not a fearful person. I used to do stuff like hang off ice faces in New Zealand and do crazy, crazy stuff.
Okay.
Which meant my amygdala was not very well developed. But I think it was so helpful for me because I'm brave around pain, but I'm respectful with the person.
Yeah. Mickey, let's talk about respect. Come on.
Yeah. Peter, can you just a little bit dive deeper into this? Like we already discussed something about how much can we push or nudge or not nudge, push people into movement, feared movement or movement they are not sure that they can do it or it's safe to do, and the relation with the level of arousal of the patient. Can you tell us something?
It's so delicate. That is a delicate dance. That's the delicate dance that I'm like, it's so delicate because it can go so wrong and it can go so right. So it's a bit literally, if you think of it like this, you have someone who's frightened of heights, terrified of heights, but they want to rock climb, right? So what do? Hey, let's go rock climbing. No, I'm terrified of rock climbing. What do you think's going to happen if you go right? I'm going to fall, I'm going to break something. Okay. Do you trust me? Well, if they don't trust you, you can't take them rock climbing, right? It's number one. You have to build relationship. If you don't have trust, you can't do exposure work. If you're not listened, the patient's not listened to, validated, heard, if their story is not deeply heard, you can't take them on that journey. So that's rule number one.
And that can be the root of failure sometimes.
Completely. And I hear it all the time. I tried that bloody CFT and we just got people bending and they never came back. It's like, yeah, go figure. Did you ask them what they were thinking? No. Did you get permission? No. So you can't literally imagine if you were taking some rock climbing and they go, I don't want to rock climb. You go, yeah, come on. You just drag them onto the rock. You tie them up on a rope and you haul them up the rope. They will never come near you again, right? That's how it is for our patients. Like this guy, just to go from sit to stand, was terrified of not using his hands today.
Yeah.
Terrified. Like, what do you think could happen? Could end up in hospital. Okay. Are you feeling brave? Do you trust us? Do you trust me to try something? Literally, you have to ask. Let's just imagine it. Let's just imagine the movement. Let's get you to do it on a high position. Let's get you to break it down. And that's where you do graded exposure. So you might start with a thought and then you start with looking. Let me show you. Let me show you what it looks like. Can we bring back an old memory? You used to mountain bike. What was that like? You had power in your legs, you relaxed in your upper body. Where's that guy gone? That guy's still sitting here. So we can bring back a memory of something that in your past where you knew that movement because it's never lost. And then we can experiment in a very gentle, graded way. And then if the person gets distressed, we're like, back it off, no worries, because we've got another day. There's always another day to rock climb.
But Peter, do you think that we can think like we can do to maximize the effect of the experimental the behavioral experiment that we can try to we have to choose the most powerful behavioral experiment that the relationship allow us to be done.
I think be careful, because unless you fully understand the context of the person, unless you fully understand it, trust is it's so hard to win and it's so easy to lose and you can't get it back.
True.
So I would say if you're sitting on that rock face and there's a chance the person's going to fall, and they will lose trust in you, you don't get a second chance. And where do they go then?
Okay, so
it's so much better if you take a little bit more time to build the trust. And that's probably one of the things that, it's tricky, because in my work, people often go, whoa, I would never have pushed that person that far. And yet there are other times where I'll just back right off. And that's because I can sense the level of fear or stress in that person. So the person I saw today, she's highly anxious, very fearful of standing, of walking, of bending, right?
And lifting sometimes.
No, she didn't lift.
Okay.
This person I saw today. So I started her lying down when we started to get movement and breathing. And then we started from sitting, and then we started from sit to stand, and then we started standing and walking, but we did it really gradually. But I took her story, I validated her, I built a trust, I acknowledged her concerns, I tested her out. I made sure that she always felt in control. And that's why we call it exposure with control, because the control is not us. It's about the person feeling in control. If they feel out of control, and it can go badly. So the control bit is about that person feeling they have control. Because what we know about pain, right? If you have pain and it's intense, it's uncontrollable, and it's unpredictable, it's really scary. If you have pain that's intense, but it's controllable and predictable, it's way less scary. So that's what we try to build up within those behavioral experiments, is the perception of that person being in control. And that's why you need such an important dialogue with that person. You're checking in all the time. And if they're not talking to you, watch their face, because usually you'll see the distress in their face. And if not the face, if they're someone who shuts emotion away, you've got to make them talk. What are you thinking? Tell me, speak to me.
Yeah.
And they might go, I'm terrified. I'm like, do you feel safe though? Because it's okay to be terrified as long as you feel safe. But if you feel terrified and unsafe, make them feel safe.
Yeah, okay. Now I'm with you.
Do you get it?
Yeah. I think it's all the matter of terminology and the level of this ability to sense and to push and to have a consent, an informed consent from the patient for what we are doing together.
Yeah.
And I simply see that all around us, some colleagues on average tend to be just a little less
cared,
less brave, and sometimes the patient can reach all they need, because the patient and the therapist want to stay away from bad feelings.
Yeah, I get it. It's part of the dance. It's like
bad feelings.
That's why it's so hard to say it's this or that, because it's about the individual. It's not about. This is why CFT is like a model of care. It's not like, oh, you do A, B, C, and D, because it's different for everybody. The start point's different. There are some people you can push so damn hard. Like, the young woman who I saw, literally day one was to learn to relax her body. That was it. Day two, I smashed her. Her legs were literally like shuddering and shaking. But I needed to build the sense of safety up. I needed her to trust me. I needed her to learn to relax in her body. And then it was like, and then today, third day, I smashed her again. Like she said, the DOMS was so bad, she was hopping around the house. But I'm not like, that is so cool. It's different pain. You know that pain. That's a pain you know. It's a pain that's good. It's a pain that means you're going to get stronger. And so sometimes we just got to be super delicate, and then we go for it. And it's just when we go for it. We got to be delicate about when we go for it and how hard. So it's not about us. Again, it's not about us. It's always about the individual. around what's safe for them, what they perceive is okay.
And we can see if it's we over pushed if the relationship is gone.
100%. Yeah.
Okay.
You bet.
That's the outcome.
Look,
that's the outcome.
I'll give you another. Yeah, the relationship, you got no chance. They will never come back. Those people literally don't come back. And then you've lost a massive opportunity that you might have just taken another couple of sessions and you still got the relationship. And I've done that, 100% done that, where I've blown someone up and I've never got a second chance. And I've gone, damn it, that was about me. It was too much about me, trying to show them that they could do this thing. And actually it's backfired.
So if the patient came back, that was not over pushing.
Or they trusted you.
Or they trusted me.
Yeah, that you over pushed them, but they came back because they trusted you. So I, another lady who I saw, a couple of weeks ago, like just a crazy history of comorbid mental health, widespread body pain, not sleeping, insomnia, social isolation. I mean, these are very common I see a lot of these people. And she came in with, 20 scans, maybe, of every single bit of her body. Okay. She's like 58. So you imagine what those scans look like. There's lots of stuff on those scans, labral tears and, tendon tears and disc bulges and God knows what. And I spent an hour and a half, I think, with her. I went way over time, validated her, listened to her, reflected, and then, outlined all the factors that we know can drive pain and sensitivity in the body. And she walked out literally and said, he said it was in my head and he didn't look at my scans.
Yeah.
So I had a phone call with her and I'm like, hey, I'm so sorry. That's what you took from that, because that is not what I intended. Can you come back in? We'll look at those scans together and then we'll revisit where to go. All she needed, she felt like I invalidated her. I invalidated her as a person, but I didn't validate her scans, and her scans were part of her identity.
Yeah.
So I had to go through the scans the second time, but she came back pissed off. But she came back and I had a conversation with her. She came back and then we got to talk through the scans and the meaning of the scans. And then I got to examine her, the bits of the body to demonstrate. And then I did some behavioral work with her. And at the end of the session, she's going, I get it. But it took me 2 sessions. And if I didn't know she'd come back, thought I might have lost her. Now, I've never, ever told a patient their pain's in their head. I never, ever would say it. It's deeply invalidating, but that's what she took from me. I'm like, what? I literally typed it all out. None of, just the role of sleep and mood and anxiety and stress and inactivity and social isolation and all of these things we know can sensitize the system to cause pain. And I literally said, you've got signs, you've got tendinopathy and bursitis, and, these are signs of inflammation of the body that are influenced by these things. So that's real. These are real structures that hurt. But there's no sign that your body's damaged. And that's the bit that really upset her, because she's going, you haven't looked at my scans. I've seen all these other people. They've told me I'm damaged, and you've told me I'm not. Why should I believe you over the doctors and the surgeons who've told me I'm broken? Yeah. So hard. That's the health system, right? You're up against it all the time. But she trusted me enough to come back.
I think Greta is smiling because we are so reassured that these things also happen to you.
Yeah, it was exactly what I was thinking. That's super useful, because you think, oh, these things happens even to Peter O Sullivan. Okay, that's normal.
Look, I think let's be clear on this. There's nothing special about me or what I do. Like, I'm just another person who's grappling with complexity, basically. So don't put me on a pedestal.
Yeah. That's
try to do it.
I mean, people, when they look at this approach, they think that it works just because it's you, right? And I think
but let's be clear on one thing. Like, none of the clinical trials do I treat anyone.
Yeah, exactly.
And, I think this is interesting you say that, because people go, oh, well, it's on the stage. And like, well, this happens in the clinic every day, not with me, but with the people I work with. So, and I think that comes down to our self-efficacy. Like, what are the tools you need to be a really effective clinician? You have to be bloody good at listening. You have to deeply care for people. You have to believe change is possible. You have to be experimental and flexible, and you need a big toolkit. Like, they are the preconditions. But we know from lots of research, there's not one way to get to a destination. There's lots of ways, but there are fundamental things that need to change. So if someone has chronic pain and they're disabled, at some point, you will have to give them strategies to reduce things like catastrophic thoughts, to build their confidence in their body, to reduce their fear. How you go about doing it, don't think it matters. What we've been working on is one way of going about doing it, which actually seems to be really effective. It's not saying that other ways aren't effective. It's just saying this is one way that we've found to be effective. And, when we look at the things that mediate the treatment effect, are the things that we target, like catastrophic thoughts, pain-related fear, levels of confidence in the body, shift in, beliefs. So there are things that change. We need to change those things. Otherwise, people just get stuck.
Peter, just a question about the relationship between the changing of make sense of pain of the patient and their behavioral change. What's the relationship, in your opinion? We need to change how they think to changing long term how they behave, or there's
well, probably not. Behavior is probably the most important thing. So, but if you can change them both, it's a bonus. So if you take something like knee arthritis, for example, and JP Canero, I don't know if you've seen the case series that he published, which is a really lovely paper, right? Because he followed 4 people, right? And the thing that changed, they still had a knee arthritis. So like, they still got an arthritic knee. They're just their behavioral response to it's changed. So instead of going, oh shit, I got an arthritic knee, I better not load it, I better not use it, I better protect it. They've gone, I've got an arthritic knee. I need to move it. I need to load it. I need to use it. I need to exercise it. I need to manage my sleep, my mental health, and my diet to optimize the health of my knee. So that's a kind of shift in understanding. That's the making sense bit. That is important, but the behavioral bit's the key, because the making sense without the behavior change is a complete waste of time. You can sit there making sense of something. Like, I could make the sense of the fact that I smoke and it's bad for my health. It makes complete sense, but I keep smoking. So unless the behavior changes there, it doesn't work, right? So there are two pieces that are required. And fundamentally, I think we massively overcomplicate the way we educate people. Fundamentally, they need to know, is it safe or not? Literally, is it safe or not? Because half the time they just want to know whether they get on with it or not. Is it safe to me to go for a run? Is it safe for me to pick up my kid? Is it safe for me to go for a walk? And then what is the meaning of this pain? And when I get it, what can I do to have control over it? Like, it's not rocket science. I think we make it so complicated instead of going, is it safe or not? What is the meaning of this? And rather than me trying to talk you into it, let's explore this together and see what your body tells you.
Yeah. We are talking a lot about emotions and behavior and cognitions and memories. And it comes to my mind, this thought. So I think that our professional identity should be more educated, more trained in psychology issues. And if I imagine in the future, I hope that in 10, 20 years, there won't be such different figures. So the psychologist, the physiotherapist, I think that those figures should be mixed. But we have a lot of struggles here in Italy, and I think in other areas of the world too. Yeah, because sometimes we are told by doctors or people or other physiotherapists too that we shouldn't integrate those emotions and cognitions in our practice. Crazy, that's crazy. What do you think?
Is that
crazy? It's like you shouldn't be treating humans. Go and treat robots or build houses or something. Do something different. Like, it's nuts. If you have pain and it stops you doing stuff, it is distressing. I've had it. I know what it's like. Pain is deeply emotional when you don't understand it or it threatens you. And if you don't want to deal with that, get out of the job.
Yeah.
It's bonkers. It's crazy. I hear this all the time. And the saddest part is that for the patients who we work with, we have psychologists who don't understand pain, who don't treat pain. They have the same pain beliefs as society. We've worked with psychologists who are terrified about exposure. They watch us do exposure and they get distressed themselves. So who's going to treat the person who's frightened? Who's going to treat the person who's distressed? So if the physio is going, don't want to know about your distress. And then we've got, the psychologist can deal with your depression. But what about the pain that drives depression? What about the pain that stops you doing the stuff that you love that drives your depression, or the pain that keeps you awake so you're so exhausted that you have no energy to do the things you love? Who's going to manage that? So it's just bloody stupid that we think that. It just doesn't make any sense to me. It drives me crazy when I hear it. I'm like, you're in the wrong job. Even if you're a vet, you'd still have emotion. You'd see a cat that's distressed and you'd pat them. You'd see a dog that's frightened, you'd calm them. That's just being human.
Yeah.
Why would we separate the mind and the body? It just biologically is dumb. It's massively invalidating of the people we work with. It limits our skills and ability to care for people well. I mean, even if you're a manual therapist, I can tell you right now, the best manual therapists I've ever seen are the ones who deeply care, who are very good communicators, even if that's your only tool. Because what does good communication skills protect you from? You never get sued. You like your job more. Your patients like you more. You're never going to be without work. You just can't lose.
Yeah.
So I hear this all the time, and it's just dumb. I have no tolerance for that argument. I think it's just crazy. And they go, send it to the psychologist. And the psychologist goes, well, don't come and see me about your pain. I don't know about your pain.
Yeah. And
so massively we have to change. And that's why that paper that we wrote together, Stephen Linton led, I think is so cool. It's like, what is a pain clinician? What are the skills and the competencies required for a pain clinician? That's what we should be asking. How do we best serve the needs of the people we care for? We should be asking that question, not what is my identity and what's my scope of practice? It's like, what are the needs of the people we care for? Mm. Who's going to provide that? Well, we know psychologists in Australia are completely booked out because of the burden of mental health, right? We have a ready workforce in Australia of physical therapists, of physios, right? We just need to upskill them.
Yeah. Completely agree.
Especially because, the burden of fear of movement, self-efficacy, beliefs is so huge for people, and we're just denying that, and nobody's taking care of that. It's so frustrating.
No one. So, and we hear this from the qualitative studies. What do patients tell us about healthcare? They don't feel listened to. They don't feel validated. They don't feel heard. Their own preferences are not taken. They don't work in partnership. They're telling us this, and we're like, oh no, we don't do that. We want you to consider our concerns and our worries and our fears, and develop interventions that support us in our journey. Like, they're asking for it. Like, we don't do that. I'm like, what? Crazy.
Peter,
Okay.
when you try to refer a patient to a psychologist, in which situations or
Yeah, so we have a psychologist. We're lucky in that we have a psychologist who works in our practice. So the kinds of patients that we would refer through, I'll give you some post-traumatic stress. So people have had, early life or major trauma, that is, recurring. It's a recurring trauma, and they're having flashbacks. And, it's a lady I saw last week, and she'd had a big nearly died in a motor vehicle accident. She gets in the car and she starts shaking. So, I can work with her, but we need additional support for her. Generalized anxiety disorders. So when it's, pain might be a focus of anxiety, but actually it's pervading the person's whole life. And it's disrupting their ability to go to work and their ability to socialize. So that's much bigger than pain itself. So that's someone who I would get additional support for. Depression, when it's like you can get reactive depression from pain, where, this person said, I've never been depressed before. I had this injury. I've been out of work. I can't play with my kids. We see a lot of that. Those people do really well with CFT because you're treating as the person builds confidence back and they get their life back, their mood lifts naturally, right? But if you've got someone who has pre-morbid depression, and that may be, historical, there might be a family history of it, or it might be they've had a really terrible early life or whatever reason. And pain you can see this kind of push and pull where the depression is driving the pain rather than the pain driving depression. Those people we would also get involved with. Co-care. And, it's such a cool thing to work with co-care because we have a shared understanding. We have a weekly meeting where we talk through, and the patients love it. They're like, oh, I love the fact that you can share that journey with us. And it takes so much pressure off us as the therapist because we know, and it takes heaps of pressure off the psychologist because we're driving them towards their goals and building their confidence in their body, and it gives them the space to kind of work on those other factors. There's a trial actually that's just been completed in Denmark looking at CFT as a model, a co-care model of using a common framework so that the patient's again in the middle, and the therapist, the psychologist and the physiotherapist go, hey, it's like, how do we play ball together? How do we play tennis together? That the person's always in the center and we can support that person's journey. It's such a cool thing. It's such a cool way to work.
Okay, Peter, before wrapping up the episode, we would like to discuss about pain acceptance, if you'd like.
Yeah. Such an interesting thing, right? So pain acceptance, I think, is massively misinterpreted as accept your shitty life.
Okay.
And I don't accept that. But I'll give you an example of this today. Like I see a guy, he's 83, right? He gets some neck pain and back pain and knee pain, but he's doing everything in his life that he wants. He's caring for him, hangs out with his grandkids. He walks every day. He was involved in a major motor vehicle accident, really hurt his neck, but now he's got full mobility. Now he accepts that a level of discomfort is totally okay with him because he has the tools to engage with the things in life that are valuable, right? To me, that's pain acceptance. It's that whole thing around accepting the things you can't change, but developing strategies to manage the things you can.
Yeah.
I'll give you an example of myself. So I developed transverse myelitis a few years back, which was terrifying. I'd lost sensation in both my legs. And I knew I was at the university giving a lecture, and it was like, whoa, this is not cool. Stuck a needle in my foot, couldn't feel it. I'm like, okay, probably should go to the hospital. I don't know what that is, but it's bilateral. That central nervous system, I better go. So I had this lesion on my thoracic cord. But the sequelae to that was neuropathic pain, which is, I've got to say, it's just revolting. It's so horrible. It's like someone got like a blowtorch on your legs 24/7, just drags your attention, can't sleep. And literally I was given an option. I'm like, well, this is your lot. It's like, okay, so it's on me to manage this myself. So, just optimizing all of my health. Now, I accept that as I sit here right now, I have a sensation of numbness in my feet and I have a degree of burning. That's my normal. I accept it. That's just my lot. But it doesn't stop me doing anything in my life. I don't sit there focusing on it. I distract myself from it, but I accept that's my lot. And I've learned heaps from it. I've learned a different level of empathy for working with people because I now really understand what chronic pain is like. I've had lots of pain in my life, but having pain that is just non-remitting is absolutely exhausting. So acceptance is not accepting a despairing acceptance of being disabled and distressed. Acceptance is to say, you know what? I get that there's been shit that's in my past, but I'm going to move on from it. I'm going to find new ways of optimizing my health, of building confidence in my body. It may not be that I'll be pain-free, but I'll have a new understanding and a bunch of tools in my toolbox to live well. To me, that's what acceptance is.
Yeah, we agree with your definition of pain acceptance, but do we have some tools to help people with low pain acceptance to higher it?
I think we have to be honest. I think we need to be honest. Like if they're like, oh no, I've got 3 out of 10 pain, that's not acceptable. I'm like, you're a human being, for God's sake. Like really, and it's hard. It's like, can you shit? Because that's often linked to hypervigilance. It's like that pain is the only thing that they focus on their life. Hey, let's find other things that give you life meaning. Let's find play and fun and activity and engagement and social distraction and all the things that build richness in your life. So that pain is not as important. It's not at the top of your pyramid. It's at the bottom of your pyramid. So that's about being honest, but it's also about, and we know that from the qualitative studies, that people who say that they've got their life back don't say they're pain-free. Some may be, and we know there are some that literally will say, yeah, I'm pain-free. But honestly, most of the people we go, I'm sorted, that like I'm cured, right? They would say, oh yeah, I get pain, but it doesn't bother me anymore. It doesn't define me. It doesn't limit me. So it's not something I give attention to. So that's where, again, I think we need to get away from pain scores to go, hey, what's the meaning of pain? How distressed are you around pain? How much is it occupying your mind? Let's focus on the goals. Let's focus on getting your life back. Because usually once you get your life back, it goes to the background. It's not in the foreground. So that's the journey. And I think it's just being honest. I don't ever make a pain score a focus of the journey. If I want to know, does the pain interfere with your life? Does it distress you? Are you frightened of it? Does it make you worried? Does it stop you doing the things you love? That's important. The other things I'm interested in, whether it's 7, I really don't give a shit about that. Like, because I can have a joyful 7 out of 10 pain having a workout.
Yeah.
Again, it's about the meaning.
100% the meaning.
A lot of people can gain being pain-free or a lot of less pain, and some other people may have some pain left, but the thing is that pain is less devastating, less impactful, and really that they gain some easiness like you do for your symptoms, right? But that comes with just bringing them to their activities, and then pain acceptance develops in a way.
Yeah, and that's probably where things like cognitive flexibility come in as well. Like having that flexibility, go, okay, I could look at this in different ways. Like I can look at this as something that's, and we often hear this with people who've gone through their journey, often say, hey, I've grown in so many ways in my life I would have never grown in before unless I'd gone through that journey. So actually that kind of broader development around understanding your own experience and your own behaviors and understanding your body and what makes it healthy, that's a journey in itself. It's just such a cool journey. But to be fair, like we see people who are, pain is shit in their life. It's not a good thing, and it's hard. And like we can't help everybody. We know we can't, but we can do a hell of a lot better job of not buggering people up. But that doesn't mean we have a solution for everybody, because we just don't. We just don't have it. Some people have really, really, really tough lives. They've had a really horrible early childhood. They've had they might have been subject to abuse for multiple years of their life, and they carry a very heavy burden. And pain is part of that burden. And if we can help lighten that load a bit, that's great. But, we don't have really good solutions for some of these people.
Yeah. Okay, guys, what do you think?
Okay. I think we're done. Or do you have any other question?
Oh, if I can just, I just wanted to thank you, Peter. So really from the deep of my heart, because I'm grateful of your existence, of your workshops. You
talking about the pedestal.
Yeah. You know what? I'd be so much nicer if we sit around in a circle without a pedestal around a campfire.
True.
But you have no idea of how much impact you're having also here in Italy without even knowing it. We're changing masters, we're doing courses, we're really trying to push the physios and upskill them as much as we can. And the scenario is really changing in the last years. Thanks of you, really.
Or your paper.
Can I just say, it's not just me. Like I'm part of a lot of. If I didn't have the team around me, there's no way none of this work would have ever happened. I never did it on my own. I'm just one part of an amazing group of people who have a common values, really, common goal and values. But remember that I was mentored by some amazing clinicians in my own journey. And it's interesting, I was just back in New Zealand where I grew up, and I met people who I first worked, my journey began in that place. It was so lovely to kind of go back and thank people who kept me going, basically, who kept my belief that there was something to chase. There was something here that was bigger than what we'd realized. And it takes a community of people to do that. And I'm lucky to be part of a community. And I think what I love is hearing you guys. You're building your own communities, and we need to connect these communities because we want to support your community, because we love that. I love the fact you guys deeply care and you deeply think, and you're wrestling with the same questions that we wrestle with. That's super cool. And we want to support you, which is why, we've talked about our mission is to kind of create an educational platform that unites people together and builds support across countries, because we're all dealing with similar things in a different way, in different systems. So, you guys are doing the best thing you could to honor our group's work by carrying it forward. And we thank you for that, because if it didn't happen, it would have been for nothing.
Wow. That's...
Seriously.
Thank you.
Eyes are wet.
Eyes are wet. Yeah.
Okay. Yeah.
Okay.
That's
been super nice. Thank you. Thank you.
To your community, really.
Yeah, thank you. And look, I think when something touches here, it's a good thing.
Yeah, it is.
because it means that we have a common values and goals. And I look forward to meeting you guys in person in Italy. That would be fun.
That would be. Here we are.
Absolutely.
And you guys are way less combative via Zoom than in a conference. You gave me such a hard time in Basel. It was like, this is so much calmer.
Yeah, we're calm.
I mean that in a nice way. We're sparring. In Basel, we were sparring. There's no sparring today.
No.
Yeah.
Kind right now.
But we can do some sparring.
I love sparring.
Time. Yeah.
You know that.
Yeah.
You're open to that. Don't worry. Thank you very much.
Thank you so much, Peter.
What do you think, guys? Can we free him?
Yeah, can we free him?
Of course.
Lovely to chat to you guys. Seriously, really nice. We'll be in touch.
See you soon.
Thank you.
Bye.
See ya. Bye.
Bye, Peter.
Bye.
Bye.
Fisionauti è un podcast realizzato da Greta Tonelli, Fabio Bernardi e Michele Marelli, con la collaborazione di Luca Bonomi, audio engineer, e Francesca Ragazzi, grafica e illustratrice. La nostra sigla è stata creata da Luca Algisi.